So let us call upon the first presenter, Dr. Manish Bakshi. Comparison of risk factors and interventions for ROP between less than 1 kg and 1 to 2 kg babies. Yes.
Should I start? Yes, please. Good morning, everyone. My study title is Comparison of Risk Factors and Interventions for ROP between extremely low birth weight less than 1000 gram, and low birth weight between 1000 to 2000 gram. And I am a ratified member. No financial disclosures.
It's the same.
First, I want to refer on study done by Gilbert et al. In 2019, regarding epidemiology of ROP, which suggests that India is entering into the third phase of ROP epidemic due to inadequate quality of the intensive neonatal care services. And this picture depicts the ROP stages which are treatable by the conventional mode of management. But the recent development of aggressive posterior retinopathy of prematurity is a great concern to us, as it cannot be treated by the conventional mode of management but needs other modalities of treatment.
Take over from now.
So contemporary studies showing India needs specific ROP screening guidelines. As bigger and more mature babies in India, even the children with birth weight of 2000 gram can develop ROP in India. About 6.7% and 13.3% of severe ROP would have been missed using the RC or AAP screening guideline respectively. So keeping this in mind, we move forward in our study, and the aim of our study was to determine the incidence and risk factors of ROP, pre-plus and plus disease, and AP-ROP, and to compare them in between two groups of extremely low birth weight and low birth weight babies, and also to compare the difference in the need for intervention in these two groups. So it is a prospective observational study done for a duration of 12 months, out of which first 9 months was the recruitment period, and these babies were followed up for consecutive 3 months. Premature babies with gestational age of less than 34 weeks and birth weight less than equal to 2000 gram with all complete documentation were included in your study, whereas the babies with other ocular pathologies, those who were lost to follow-up, those died before the final follow-up, and babies with incomplete documentation were excluded from our study population. Screening was performed in a temperature-controlled environment where the facility for management of neonatal emergency was available. We have followed the following screening guideline during our study. If there is on first screening, there is incomplete vascularization noted, then the premature babies were observed at an interval of every 2 weeks till complete retinal vascularization. If ROP was noted on first screening, it was staged and treated accordingly. Laser and in few cases, anti-VEGF injection was given on type 1 pre-threshold babies. Close observation was done in type 2 pre-threshold baby, and anti-VEGF injection was given on AP-ROP babies. Surgery for RD done in stage 4-5 ROP, and only observation is done in other stages without RD. Software used for statistical analysis was SPSS version 20. Categorical variables are summarized using frequency percentage. Continuous variables are expressed using mean plus minus standard deviation or median interquartile range. Chi-square test was used to compare the categorical variables, whereas Mann-Whitney U test used to compare the non-normally distributed continuous variable. If p-value less than 0.05 was considered significant. Total 207 babies screened during our study, and they were divided into two groups. Group 1, extremely low birth weight baby, birth weight less than 1000 gram, n equal to 106. And group 2, birth weight equal to 1000 to 2000 gram, that is the low birth weight babies, n equal to 101. Among group 1 babies, 4 excluded due to other pathologies, 7 excluded due to incomplete data, 90 and total screen 95. Out of which 5 died before final follow-up, 10 lost to follow-up, and 80 included in study. And among group 2 babies, 2 excluded for other pathologies, 5 excluded due to incomplete data, 2 died before final follow-up, 12 lost to follow-up, and again 8 included in study. Demographics showing the distribution of the groups according to the birth weight. Mean birth weight in group 1 was 890 plus minus 90 grams, and in group 2 it was 1560 plus minus 260 grams. Distribution of the groups according to the presence of ROP showing that 63 babies in group 1 and 16 babies in group 2 developed ROP. CPAP and blood transfusion significantly modified the risk of ROP in both these two groups, whereas the use of oxygen hood and respiratory distress syndrome only significant in group 1, not in group 2. Histogram showing the distribution of different intervention in the two groups. It shows group 1 babies required more treatment than group 2 and only 7 babies in group 1 required RD surgery. Coming to discussion, group 1 neonates had a higher frequency of ROP, 78% versus 16%, p-value less than 0.001 as associated risk factors are more frequent. Incidence of AP-ROP in our study was 2.5% with no significant difference between the groups. Whereas in other studies in India, the incidence of AP-ROP reported as 20 to 25%. We believe that judicious use of oxygen may contribute a lower incidence of AP-ROP in our study. CPAP and blood transfusion significantly modified the occurrence of ROP in both the groups, while use of oxygen hood and RDS influenced the incidence of ROP only in group 1 units. These also correspond to the other similar studies. Our study have some limitations. We did not evaluate the treatment outcomes. Comparison of the functional and anatomical outcomes or the long-term effects of the different treatment modalities, laser and anti-VEGF on the evolving visual system was not possible. And finally, to conclude, extremely low birth weight babies have a higher risk of ROP compared to the low birth weight babies. Use of oxygen hood and RDS are risk factors for ROP in extremely low birth weight babies, but not in low birth weight babies. There is no difference in the mode of treatment or need for intervention in extremely low birth weight and low birth weight babies. Thank you all.
This was a cross-section study, or you had some follow-up?
I did follow up, sir.
How long was the follow-up?
Sir, the study actually we did for 12 months, and first 9 months we recruited the babies, and we followed up for next 3 months, consecutive period of 3 months. I've actually done this study during my post-graduation. So in that period I did follow up to 12 months only, then I cannot follow up.
So this was, you have taken what age they were, these children? They were not neonates, they were taken older children.
No, sir. All are neonates.
Neonates.
All are neonates.
Okay.
Those babies who have enough documentation, we have excluded it from our study.
Okay. And what was the severity of ROP? Have you tried to correlate with severity of the ROP with birth weight?
Yes. Sir, sorry.
Severity of the ROP and birth weight, you were trying to correlate low birth weight with ROP.
Yes. I have done the incidence of ROP, and I have done the incidence of ROP as a total population and divided in between the two groups also. And the incidence of ROP noted in group 1, that is the extremely low birth weight baby, was 78% around, and incidence of ROP in group 2, that is the low birth weight babies, that is more than 1000 gram babies, was noted as 16% only.
What I was trying to say is that severity is important because every child with ROP may not need treatment. We should see which ones need more follow-up, more treatment. That was my idea. Did you try to?
Okay, we did that. We have shown that the group 1, that extremely low birth weight babies actually needed more treatment, and so the severe ROP actually found in group 1 babies, that is extremely low birth weight babies, more than the low birth weight babies.
That is important thing.
Yes, sir. Yes.
But you have not shared your data on the treatment at all.
Yes, sir.
How many went in for laser? How many went in?
Yes.
Okay. What about long-term myopia and all that? You have not. You don't have.
Ma'am, we could not follow up that up to that much in our study, because we cannot put the
And did you-
long-term side effects of the ROP. We cannot.
Okay.
put in
Did
our
you see any infections with anti-VEGFs or anything you had? With intravitreal injections, anything?
Yes, intravitreal injection.
You didn't do the treatment part.
is not done.
Intervention done, ma'am. Intravitreal injection was given. No such occurrence or no such mishaps like infections or there.
Thank you.